again, from a government or a legislative perspective, we do have to report our numbers of pressure injuries. And so we review a lot of those things. So we look at our total number of pressure injuries reported through our risk management program, and we look at that per thousand, like we look at them each pressure injury itself, but we also look at the aggregate of those pressure injuries, and we tend to balance it out as how many pressure injuries per 1,000 bed days, and that allows us to look at trends over time. We look at how many full thickness injuries we have as a specific issue. The last 2 years, we've also looked at all of our risk incident data. We've actually looked and opened up every one of those and done a quick report and an audit. And so we didn't look at the whole history for those patients because there's quite a lot in that. But we did look for some key things to find out what were the patterns, if anything, for those patients. And so it's quite interesting in that space. You know, we look at about 25, consistent with the data, the international data, 25% of around of that is related to possibly IAD. About 20% of those patients, they're at the end of their life. And so those injuries have occurred in the last sort of 7 days. About 30% to 35%, depending on the year, seem to be medical device related injuries. And the remaining ones where we say they're probably pressure injuries that probably we could have done something about seem to mostly occur on the foot. So that's where we sort of look at that as a special sort of review to sort of get an understanding of the story. And I also look at the coded data as well, which is the data that appears in our notes, and to see what is getting reported as a pressure injury in that space. And so we look at that monthly. So again, we want to be across the evidence that we've got. Additionally to that, we do 2 other types of audits. So every quarter, there's a nursing bedside audit, and it's looking at processes. It mainly looks at the notes to see other things we say in our policy being done. So are skin checks documented within the 2 to 4 hours? Do we have a risk assessment documented? Do we have risk interventions documented? And then we also have asked in the past is when we speak to the patient, are they aware of what interventions they have in place? So that kind of helps us understand, have they had some ongoing education about their risk? That's much trickier to get hold of because, as you can understand, people are in hospital for a prolonged period of time. They're not that well. They might forget. They might not speak English as a first language. So that ability to recall might not be there. But they're the types of things that we look at. And then additionally to that, we do some ad hoc audits to look at particular issues. We do about 2 a year. They're not always related to pressure injuries, but pressure injuries are a big factor. So we look at, you know, are we having any issues related to certain devices? So at the moment, we feel we've had an increase related to indwelling catheters. So we're doing a bit of a view on what's happening with catheter use in the hospital, or what's happening with beds, for example. So yeah, so we look at those things to see what it actually, they're more the unusual things, but yeah, we look at those as well.
So to ensure the consistency of care, we have a whole team of nursing staff that help provide the education to the nursing staff as well as follow-up to ensure that those guidelines are being followed. So we have like specialized wound nurses, we have the unit directors and clinical nurse specialists that all help drive the staff to be able to implement the guidelines that have been laid out.